evening. Welcome you all to our regular activities of the Oncology Club. For your information, we have shifted our Tuesday program to Sunday, and in future it will be regularly on Sunday, and we will try to give the message regularly. I think it will be hopeful for, and it will be very great day for all of our faculties and other colleagues. Today is our tumor board sessions, and the cases will be discussed on the ovarian malignancy. And the presenting institute today is Sir Solimullah Medical College Hospital, and the presenter is Dr. Rizwana Afrin. She is assistant registrar from Gynae and Ops departments from Sir Solimullah Medical College and Midford Hospital. Other two presenters are from National Institute of Cancer Research and Hospital. Dr. Monju Manara Shorkar, she is a resident in Gynae Oncology, National Institute of Cancer Research and Hospital. Dr. Farhana Haq, she is resident Gynae Oncology, National Institute of Cancer Research and Hospital. And our faculties today are the Dr. Professor Amita Moheshwari. She is Professor and Head, Department of Gynaecological Oncology, Tata Memorial Hospital, Mumbai. Dr. Annie Catherine Goodman, she is Professor of Obstetrics and Gynecology Reproductive Biology, Harvard Medical School, Boston, USA. And last but not the least, Professor Dr. Joya Ghosh, she is Professor, Department of Medical Oncology, Tata Memorial Center, Mumbai. And our inspirator today are the Dr. F.M. Kamaluddin. He is the Scientific Secretary of the Oncology Club, our General Secretary, Professor A.M.M. Shariful Alam, and our the regular inspirator, Sir, Professor Dr. E.M.A. Hai, Sir, who is the President of the Oncology Club. Now, the session is to Hai, Sir. I request our Sir to give us permission and to say something about this session.
Thank you, Sana. We are already late. Please start immediately. We have faculties from USA, India, and our presenters are from Sir Solimullah Medical College and ICRH. Whether our subject matter is superior cancer. Let us start immediately.
Thank you.
What, Sana?
Thank you very much. Yes, we are at least late, 15 minutes late. And our first presenter is Dr. Rizwana. She is from Sir Solimullah Medical College and Hospital. Rizwana, please present your case.
Good evening. Am I audible and the slide visible?
Yes, you are audible and your signs are visible. Please start.
Thank you. Mrs. X, 23 years old, 5th gravida, para 2 normal vaginal delivery, plus 2 abortion.
She is disconnected, sir. Rizwana?
Yes, madam.
Yes.
Am I audible, madam?
Yes.
Thank you, madam. Let's start again. Mrs. X, 23 years old, 5th gravida, para 2 normal vaginal delivery, plus 2 abortion, attendant in outpatient department of Sir Solimullah Medical College, Midford Hospital, with the complaints of pregnancy for 11 weeks, pain and heaviness in the lower abdomen for same duration. Pain was dull aching in nature, but she noticed excessive enlargement of her lower abdomen than her gestational age. She is married for 6 years, mother of 2 living children. Age of last child was 3 years. She attained her menarche at the age of 16 years, was a regularly menstruating woman. Her menstrual cycle came at the interval of 55 to 60 days with average flow and duration. Her last menstrual period was on 10th March 2021, and accordingly, her EDD will be 17th December 2021. Couple used no method for contraception. She has no family history of breast, ovarian, colon, and endometrial cancer. Patient is non-hypertensive, non-diabetic. Her bladder and bowel habit was normal. On examination, her BMI was 26. All vital signs were within normal limit. Thyroid gland not enlarged. Breast examination revealed no abnormality. Accessible lymph nodes were not palpable. On para-abdominal examination, a 15 into 13 centimeter size mass occupying hypogastric and umbilical region. It was mobile with smooth surface, non-tender, and cystic in consistency. On pelvic examination, vulva, vagina, and cervix were apparently healthy loop. Uterus 10-week size, mobile, non-tender. A cystic mass about 15 into 13 centimeter size failed through right fornix. On parectal examination, rectal mucosa free, and there was no deposit on pouch of Douglas. Now diagnostic workup. An ultrasonogram of whole abdomen was done on 17th June 2021, which revealed 11 plus week single live pregnancy, bilateral big multiloculated ovarian cyst, right one 20 into 17 centimeter and left one 13 into 10 centimeter. Mild ascites at present. Regarding her tumor marker, CA125 was 458 international unit per liter. Other tumor markers were within normal limit. Patient was advised with routine antenatal investigation. All of her investigations were normal except for thyroid function test. Her TSH was more than 100 microinternational unit per liter. FT3.60 picogram per ml, 1 international unit per ml. Now, how will you patient?
Please.
Yeah, so thank you. An interesting case. So one thing I would, want to know a little bit more about ultrasonography. Are there solid areas in on ultrasound or not? Because see, one and the first possibility I would keep in this case is ovarian hyperstimulation, because her TSH is very high and it acts like LH. So I don't know whether she got, hyperstimulation kind of syndrome. So I'm not sure if you are dealing with the malignancy or it is just multiple cysts because of ovarian hyperstimulation. So a little bit more on ultrasound. Were there solid areas on ultrasound?
Rijona?
No, yes, ma'am. Yes, madam. There was no comment about any solid area present in the ultrasound.
So I would be interested in knowing, a little bit more on ultrasound. And at 11 weeks of pregnancy, if she doesn't have any acute symptoms, maybe I will carefully observe her. And if patient cannot reach the hospital immediately, I'll keep her, I'll, admit her, but I think I won't plan anything immediately. And what you said, high CA125. So during pregnancy, CA125 can be high. That's not a very reliable marker. So that will be my plan. And of course, she needs, further evaluation of her abnormal thyroid function. So which we need to check what is the reason for her, and if does she need supplementation for her TSH. So does she need altroxin?
Okay, proceed. Vijana, proceed.
And the
Yes,
only
ma'am.
other,
Yes, Joy, please. Joy.
no. So of course, not so much for this patient, but because this is like a teaching sessions, like at the age of 23 years of age, I mean, the ovarian tumor that we would normally think of is germ cell tumors. And of course, AFP and beta HCG can be high as per even in pregnancy, but like if they're out of proportion to what we expect for the gestational age, and of course, that would be more of a solid tumor. But if this patient suppose did not have pregnancy, then the germ cell tumor markers would have been the first thing that we would have done for somebody who is 23 years of age to rule that out. So AFP, beta HCG, and LDH also for her. Yeah.
Yes, all were done and all.
The patient was referred to endocrinologist, and she was advised with tablet levothyroxine 50 microgram, 2 tablet daily, which was gradually increased to 3 tablet. And patient was advised to come for follow-up after 1 month. After 1 month follow-up investigations, her thyroid stimulating hormone reduced to 6 microinternational unit per liter, FT4 10 nanogram per dl, and CO125 reduced to 150 international unit per liter. Now, what other diagnostic workup she needs?
So a month later, I think if you will repeat imaging again to see size of ovarian masses, if there is any reduction or they are of the same size. And of course, now she's around how many weeks? So 11 plus around 14 weeks?
15 weeks.
15 weeks. So 15 weeks, maybe at now or little later, we will do ultrasound for fetus also, like, obstetric ultrasound for anomalies. Of course, that's generally at 16 to 18 weeks.
Next.
Thank you, ma'am. Now, follow-up ultrasonography of whole abdomen, which was held on 17th July 2021, and which revealed bilateral big multiloculated ovarian cysts. The right one 16 into 11 centimeter, and the left one 13 into 9 centimeter. Mild ascites at present, single live fetus about 15 plus week size with good physical activity, and placenta is posterior and away from the os. This is the picture of MRI of whole abdomen, which revealed normal abdominal viscera, and this is the MRI picture of pelvic structure, which showing gravid uterus along with bilateral large multiloculated mass with no ascites and no lymphadenopathy. This is the picture of MRI of whole abdomen, which reveals gravid uterus along with bilateral large multiloculated mass. Right one 10.5 into 8.3 centimeter, and left one 9.8 into 6.4 centimeter, with no ascites and no lymphadenopathy. Now, what other investigations should be advised to this patient?
Okay.
So I completely, first of all, beautiful presentation, very interesting case. And I completely agree with Amita. I mean, I think that this is a situation where you sit on your hands and watch. And my first diagnosis would be that she has theca lutein cysts, probably from the hypothyroidism that she had. And then she had the stimulation by the TSH. You've now had an intervention, which is wonderful, and hopefully will prevent her fetus from having anomalies and lifelong disability from that. And so hopefully that'll be okay. What I don't really know is when you develop large theca lutein cysts, how long does it take for them to resolve? I think the standard recommendation is to leave them alone, and sort of kind of follow along. So I would say if you have a healthy fetus, the mother is looking good, her labs are normalizing, I would sit on my hands and have her come back in a month, repeat imaging, repeat fetal survey at that time. I don't, ultimately, as with all things, your decision is going to be, do you have an intervention or do you watch and wait, right? I mean, that's always your decision for everything, and especially in pregnancy. So we always try, if possible, if the mother is safe, to wait till fetal viability. But you can have an operative intervention, and the best time in pregnancy is usually around 20 weeks, okay? But definitely in the second trimester after the first trimester in major organogenesis. But I'm not really seeing anything in terms of symptoms. She doesn't have torsion. She doesn't have an acute abdomen. She's going to probably continue to have these persistent cysts. I'm curious if anyone else has a sense if these are theca lutein cysts, how long they take to resolve. But that would be my recommendation.
Next.
As patient was having bilateral multiloculated big ovarian masses, so we advised the patient for endoscopy and colonoscopy, but she refused to do.
So if I may just add here, patient who is asymptomatic, her tumor markers are normal. And, MRI is not showing any solid area. So these are just simple cysts with elevated TSH. In this clinical context, I think I may not even ask for endoscopy, although this patient refused. But I won't, if, anything, I may first do a stool for occult blood, but I will definitely not suggest an endoscopy, because colonoscopy during pregnancy, it has its own, complications, even upper GI endoscopy. So that's my take. I don't know what others feel.
I completely agree. I would do nothing. I would watch her carefully. Yeah.
Yes. And especially you have to see in the clinical context, her CA-125 has come down. There are no solid areas. She doesn't have GI symptoms. So I think in our provisional diagnosis, it's a functional cyst, not a malignancy. Dr. Kamaluddin, you want to make a comment? I can see you have raised your hand.
Yeah, I mean, I raised my hand to say that I'm there, number one. Thanks for joining. And I think Amita raised a very important thing, because in our mind, whenever we are seeing a bilateral something, we are jumping in for endoscopy and colonoscopy, which is good. But sometimes we need to understand that all are not tigers. Sometimes there's a cat. So as she mentioned that there is no definite feature in favor, so pushing for some endoscopic colonoscopy may not be a reasonable thing. So whenever we are thinking about looking for bilateral ovarian mass for endoscopic colonoscopy, at the same time, we should also think when we should not do it. So that is the point I wanted to mention, that we should be thinking in both the direction, not only unidirection. That was my point.
Right. So, and as AK very rightly mentioned, that in pregnancy, we have to be very, very careful advising any investigation. So, even although it is in a non-pregnant women, it's okay. But second trimester of pregnancy, colonoscopy is not an easy procedure.
And the timing is important because at this time, even we see something, nothing is going to change at that time. So suggesting some investigation at this time, we should be very cautious.
Yeah, especially in the context when you don't have any clinical suspicion of malignancy. So I think.
So I think we can proceed.
Rizana, proceed.
Yes, ma'am.
Proceed.
Now, is there any association of hypothyroidism with bilateral ovarian enlargement?
Yeah, we just discussed that. So.
This is already discussed, I think, already discussed.
Yeah.
Now, what will be the appropriate treatment option for this patient?
It's also discussed.
Yeah, this also.
We already discussed this.
Yes, next.
Shahana, this is discussed.
Now, our possible diagnosis was early pregnancy with struma ovary, mature cystic teratoma, serous cyst adenoma, and dysgerminoma. Our respected faculty also include here bilateral thecal lutein cyst also. Now, in pregnancy with ovarian tumor, which trimester is preferable for doing surgery?
So as I said before, usually the second trimester, you want to wait until you have major organogenesis, so you're not exposing the embryo, then fetus, to teratogens that could cause cleft palates, cardiac abnormalities, and so forth, in the setting where it's a non-emergency. Also, technically, in terms of operating, whether you do it laparoscopically or an open laparotomy, the size of the uterus will get in the way in the later gestation. So by the third trimester, it becomes quite difficult to get around. And a lot of times the adnexa is lodged in the cul-de-sac. And so you're kind of groping back there and so forth. And in the second trimester, that's sort of an ideal time. You could either make a small incision, vertical incision at the level of the umbilicus, a little paramedian incision, or you could do laparoscopic surgery if you have that ability, and quite safely, without stimulating the uterus, do what you need to do. Yeah.
Next. Rizana, please.
So laparotomy or laparoscopy, which one is more preferred? If laparotomy is done, which incision is preferable?
Next.
Thank you all for patient hearing.
Okay, thank you, Dr. Rizana. Our next presenter is Dr. Farhana Haq. She is resident gynaecologic in National Institute of Cancer Research and Hospital. Farhana, please stop sharing.
Am I audible?
Yes.
Slides are visible?
Yes.
Honorable President, respected faculties from home and abroad, and learned audience, Assalamu alaikum, and welcome you all to our case presentation. Mrs. X, 56 years, para 2, living 2 lady, attended in our outpatient department with the complaints of parvaginal watery discharge since 2019. Several episodes of postmenopausal bleeding for same duration. She had a history of left hemicolectomy for sigmoid colon carcinoma in 2016, and histopathology report was adenocarcinoma grade 1. She received 6 cycles chemotherapy with oxaliplatin and capecitabine from June 2016 to October 2016. Then she lost for follow-up. With this above complaint, she visited to a local gynae in December 2020 and underwent dilatation and curettage, but unfortunately her histopathology report was lost. Due to these persistent symptoms, we advised her fractional curettage, but she denied due to COVID pandemic situation and her financial constraints. She wanted to get treatment in single sitting. On examination, her ECOG score was 0. She is mildly anemic, obese, no lymphadenopathy, no mass or organomegaly was found. On pelvic examination, uterus was 10-week size, cervix was looking healthy. A TBS revealed there was a mixed large echogenic mass about 4.5 into 3 centimeter in the endometrial cavity with inhomogeneous myometrium. Ultrasonography of whole abdomen was normal with bulky uterus with fatty liver. Chest X-ray was inflammatory relation in both lung and CA125 was 42 unit per ml. MRI of whole abdomen showed there is endomyometrial interface is indistinct and there is asymmetrical enhancing wall is seen in the uterus. And in T2 image, there is a central part of the uterus show heterogeneous hyperintensity. Adenoids appear normal. This is a known case of colon carcinoma with postmenopausal bleeding patient wants to get single sitting treatment. What will be her management?
Okay, please. Okay.
This is a complicated case, and I'm really interested in actually Kamal and Amita and everybody's thoughts about this. I mean, my first thought is to consider a surgical option for, secondary cytoreduction. What are other people's thinking about this?
Yes, yes, I agree. I would also consider surgery, but she doesn't have any ovarian problem now, right? No. It's just a uterine mass. So, I would suggest surgery at a place where frozen section facilities is available. So, if it is, and it looks quite, on MRI, there is definitely a very, suspicious looking mass. So if frozen suggests malignancy, we do comprehensive surgical staging as per us, we do for CA endometrium. The only other thing, because she's a known case of colonic cancer and now uterine malignancy in a 56-year-old lady without other features of, of type 1 endometrial cancer, I think we also have to ask for MMR on tissue if possible. So immunohistochemistry for MMR gene, proteins.
Yeah, and of course, this patient insisted on being a single sitting, but otherwise one would have gone ahead with at least a sampling or a curettage.
Yeah, so she apparently had biopsy once and tissue was lost. The only other way is, if biopsy financial constraints are not there, then endometrial aspiration can be done in the OPD if that is being practiced routinely. Otherwise, in this case, maybe single sitting is okay because uterus needs to come out. Did she receive radiation for her colonic cancer? Was she radiated also?
No, ma'am. She only received 6-cycle chemotherapy.
Is there family history of Lynch type malignancies?
No. She had no family history of those type of tumors.
But still, if it is endometrial malignancy, we would like to do MMR.
Yes. I have a question to all three of you. I mean, Jaya, Amita, and AK. That what Amita was trying to bring up. That we are getting two malignancy. One is colon. Colon is very much related to, the family histories and other things. Is there any genetic link between endometrial and colon?
We are proceeding. We are with this.
Yes, the Lynch syndrome.
Yes.
That is good.
I think there is, up for discussion, Dr.
Okay.
Yes.
Okay.
Next discussion. Yeah.
Second question already discussed.
Yes.
She underwent endometrial curetage with frozen biopsy followed by laparotomy. Frozen biopsy report became positive for malignancy. So peritoneal washing, total abdominal hysterectomy with bilateral salpingo-oophorectomy, bilateral pelvic and para-aortic lymphadenectomy was done on 20 July 2021. Perioperative findings, there was no ascites, omentum was healthy looking, uterus was 10 weeks size, perioperative section showed there is 3 into 2 centimeter endometrial growth, invading more than half of the myometrium. Adnexes are normal. Both sided pelvic lymph nodes were enlarged. The final histopathology report was papillary serous adenocarcinoma grade 2 with more than 50% myometrial invasion, lower uterine segment involved by the tumor, lymphovascular invasion present, and both pelvic and para-aortic lymph nodes present showing metastasis. So as the histopathology report is papillary serous adenocarcinoma, during surgery, her omentum was healthy looking and frozen section cannot mention the cell type. So omentectomy was not done. So the question is, what can we do now?
No, nothing. No need to go in again to do omentectomy for sure. And that, you know, had we had a biopsy before, that's the advantage. Your surgery can be, you know, as per histopathology, but there is no need to go in again to remove the omentum.
Okay, madam. Usually in Lynch syndrome, endometrioid type of endometrial carcinoma occurred, but here histopathology is papillary serous type. Is it related to Lynch syndrome or separate primary?
So as Amita says, she needs genetic testing to determine Lynch syndrome. For sure, you know, about 10% or so of all endometrial cancers will be associated with Lynch syndrome, and with immunohistochemistry staining of the tissues, you can sort that out. What's interesting is that she has a serous subtype, which I think is less associated with Lynch syndrome than the endometrioid subtype, if I'm correct, and please add to that.
Yes, yeah,
my friends. Yeah, you know, so I'm curious that she has a serous subtype. Unfortunately, she has several poor prognostic factors now. So she has a stage 3C2 cancer, right? Because she has positive periodic nodes. And really, I think the standard now would be to treat her with upfront chemotherapy with 6 cycles of carboplatin Taxol followed by radiation. So her risk factors include a high risk histologic subtype, which is serous, a deeply invasive tumor with lymphovascular space invasion. In addition, she has spread to her lymph nodes. So she has the risk of distant recurrence plus the risk of local recurrence, but probably distant recurrence is more likely, and starting with chemotherapy would be the right thing to do. In terms of this being genetic, again, you know, you don't know without testing, and you could also take a very careful family tree for her. It sounds like you've done a little bit of that, but ultimately, really, it's getting on board with more chemotherapy for her. Yeah.
Madam, due to this disparity, shall we go for our slide review?
Yes, I think slide review, and also you know, other features in favor of Lynch type is lower uterine segment. And I don't know, you have written lymphovascular space invasion, but also look for lymphocytic infiltrates. So lower uterine segment is more often seen with the Lynch syndrome patients, and lymphocytic infiltrates also common there. The other marker we need to do here is P53. If it's a serous histology, it has to be P53 mutant. So that will also help in knowing whether it's really serous or poorly differentiated, because many times Lynch may have poorly differentiated carcinomas, and pathologists can confuse, or, you know, between poorly differentiated and serous histology.
We sent immunohistochemistry, the report is pending.
Okay, update us on his immunohistochemistry report.
Yes,
Was it necessary?
And P53 also, just MMR and P53. I would say we need to do
Yes,
both.
madam. We have already seen. Was it necessary to do an immunohistochemistry for MMR during her initial diagnosis of carcinoma colon?
If possible, I would say yes. If it was available and finances were not, it was a right-sided colonic cancer, right?
Yes.
That is a common practice, recommendation now to do upfront.
Right. So if financial constraints are not there and if facilities available, yes, we should.
So MMR is IHC, it is not a very expensive, it is not.
Yeah, but last time we discussed and we were told that it is.
5,000, yes.
It is
5,000. 5,000.
A patient who couldn't afford a DNC because of financial constraint, I think MMR also will be.
It is done in our hospital, everything done in government hospital and free of cost.
Oh, okay.
Next.
If MMR positive, how can it help to prevent future endometrial cancer? Regarding diagnosis of colon cancer.
So that's a great question. I think for this patient, clearly we're beyond that, but it is useful information for her family, for her children, for her brothers and sisters, that they should be tested. Say for hypothetically, we knew that she was MMR positive after her colon cancer diagnosis, then part of the counseling for her would have been to recommend a prophylactic hysterectomy BSO. Again, depending on her interests, for people who are still at childbearing age, you would recommend at least a yearly endometrial sampling to survey and monitor the endometrial lining. But at some point, you think about recommending a risk-reducing hysterectomy. And that would be true for her family members who test positive. And then, of course, for family members who test positive, they need to have colon cancer screening, colonoscopies on a yearly basis.
If MMR and P53 positive in recent immunohistochemistry, how can this influence our adjuvant treatment?
Joya, please. Joya, please. Is she not here?
She, I think, got disconnected. Okay. So, see, more than immunohistochemistry, because she's stage 3C2 disease, her adjuvant treatment would be chemotherapy, and we give paclitaxel and carboplatin 6 cycles, plus minus Volt brachytherapy. So that's the protocol we will use in this patient.
Join.
Yeah, sorry, I lost connection in between. So what is, I missed out on the question.
Yes. MMR and
question.
Yes.
MMR and P53 positive in recent immunohistochemistry report. How can this influence her adjuvant treatment?
Okay, so because she is node positive, so she would need chemotherapy anyways. And of course, if MMR is a prognostic factor and, those who are MMR positive do well. But, if she is node positive and in case she comes out to be MMR positive, we would still give her chemotherapy. We will not, although there are retrospective data to say that, those who are MMR positive may not benefit so much with adjuvant chemo. But I think the fact that she's node positive would, still change her management, and we would continue with, at present, at least 4 cycles of chemotherapy and followed by radiation. That's what we do.
Yeah, so if it is P53 mutant, I think MMR takes the back seat. So, and stage is also important. So she's stage 3C1, C2, sorry.
So I think sorry, I think the issue of the MMR being positive in terms of therapy is something to consider for recurrent disease. At least in the United States, currently, our Food and Drug Administration approves the use of immunotherapy in endometrial cancer, that is MMR gene mutation positive, both germline and somatic. So that's interesting, in the setting of recurrence after chemotherapy. So it would not impact decision-making around primary therapy, primary adjuvant therapy, but it would in the consideration should she recur.
Yes, absolutely. And see, one more point, if she is, her tumor is positive on IHC MMR protein, then she actually needs a proper genetic testing, germline testing. And if it is Lynch syndrome genetic mutation, because there could be MMR, this thing could be somatic or genetic. If it is somatic, she doesn't need, but if it is genetic, if there is germline mutation, then what Teki described, it has implications for other family members and for her as far as breast is concerned. So she needs screening for breast and colonic cancer.
So someone has written regarding EBRT to the lymph nodes. So of course, I don't know from someone from radiation is there or not, but essentially if we've done a complete lymph node clearance and we are giving chemo, I'm not sure that they will address the radiate nodes also, Dr. Amita.
We by and large no, but Dr. Kamaluddin, what will you do? I mean, if we have to give inverted V kind of field, which will be, I don't know, in this lady, will it be very toxic after chemotherapy?
Extended field RT, we have a lot of neutropenias, and especially post chemo. So
right.
The question is,
is Dr. Kamaluddin there or has he left?
Yes. No, he's not here. Proceed. Arana, proceed.
What will be our adjuvant treatment?
It's already discussed.
It's already discussed.
Yeah.
Thank you all for patience hearing.
Thank you. Interesting case and good presentation.
Our next presenter, Dr. Manjuman Sarkar. I request Dr. Manjuman, she is our resident, to present your case. Manjuman, please. Can we share from here?
Yes, ma'am.
Mahfouz. Mahfouz?
Ma'am.
Yes, please share her screen.
Okay.
I've sent you the slides.
Ma'am, please stop sharing. Dr. Manjuman, ma'am.
Okay.
Ma'am, please.
The slide is not shown. It's not open.
Not open, madam.
Mahfouz?
Ma'am.
Yes.
Madam, can I share?
Yes, you please. Okay. Next.
Am I audible?
Yes, yes. Next. Next slide. Ke this it Mahapuz na Nila. Mahapuz? Nila, I take it share kurse. Okay.
Honorable Chairperson, respected faculties from home and abroad, and learned audience, Assalamu alaikum and very good evening. My patient, 22 years lady, para 2, living 2, non-diabetic, normotensive, developed lower abdominal pain 3 months back. And she has consulted with a gynecologist and advised to do ultrasonography for ultrasonography of whole abdomen, which revealed a large cyst about 12 into 7 centimeter in lower abdomen. She has no family and personal history of breast, ovarian, and colon cancer. Next. Next.
Mahapuz, next.
Her ultrasonography shows a large hypoechoic area in the lower abdomen. Origin could not be detected. Next. CT scan report shows there was a large, well-defined oval cystic area measuring about 8.2 into 11.8 centimeter in the pelvic cavity, predominantly on the left side. Next. Next. There was no ascites and lymphadenopathy. Next. In young lady with ovarian cyst more than 10 centimeter, what evaluation should be done before laparotomy?
Mahapuz, apni bolar agi sorry.
Question is, in young lady with ovarian cyst more than 10 centimeter, what evaluation should be done before laparotomy?
Yeah, I think you need to do all the tumor markers. Yeah, I think somebody has already written for germ cell tumors, alpha fetoprotein, beta HCG, LDH. And of course, you'll also do CA125 and CA99, but and CEA, sorry. And but you know, if she's 22, I think the first differential would be a germ cell tumor. And of course, others being low-grade serous and others, but those are borderline tumors, but those, of course, we can't make out on tumor markers.
Next question.
Mahapuz, next.
Next question. Should we follow IOTA protocol for taking decision in peripheral healthcare facilities?
Sometimes peripheral healthcare facilities are like Upazala Health Complex, where only the ultrasound facilities are available, no other advanced imaging. In that case, because we have, yeah.
So what is, sorry, I'm not aware of the IOTA protocol.
Yes, Amita ma'am, please. Amita ma'am, please. Oh, Mahapuz, iPhone post করেন.
করেছি ম্যাম.
Okay.
Yes, I think just not peripheral center, even other places we should follow IOTA protocol. Before embarking upon a CT scan or a MRI, we need a proper ultrasound evaluation. And if you have a good sonologist, IOTA is a very, it can give a lot of details. In fact, I find ultrasound better than CT scan for evaluation of ovarian masses. So if I have any doubt on ultrasonography, I would go for MRI, not for a CT scan.
Next question. Where frozen section is not available, can we do laparotomy in benign looking ovarian cyst?
I mean, the question is if you don't have frozen section, whether you should do it or not.
Yes.
Yes, ma'am.
I mean, if there is no choice, then yes. But in a young patient, again, you have to be very careful. You don't want to remove ovaries if it's, if it's not a malignant disease. So after explaining to the patient, and if patient can't go to a center where frozen section facility is available, and if you have no other choice, then yes, do surgery without having frozen section. But in a young patient, I would on the side of being conservative, and I will explain to the patient if it turns out to be malignant, need for another surgery, but I won't remove everything upfront unless of course intraoperative it's looking very advanced disease.
Next slide. Then she underwent laparotomy followed by left-sided oophorectomy on 31st May 2021 in a private clinic outside Dhaka. Next. Her histopathology report revealed papillary mucinous cyst adenocarcinoma, endocervical type, grade 1, and outer capsule free of tumor. Next.
I think it's a very interesting histopathology report. We generally don't see papillary or non-papillary. I don't know, Jaya, do we get, when it is a mucinous in endocervical type, do they write papillary?
Go to the previous
the
slide.
papillary was generally
Right.
Mahfouz, go to previous slide. Mahfouz. Yes.
Yes. So, I think usually they don't write papillary, but I think the word papillary per se should not have so much of connotation. So what we generally see in nowadays in mucinous carcinoma is to see whether they have these infiltrating borders or they have these invasive borders. Because if it is like the pushing kinds, that is considered to be a better prognosis as compared to the infiltrative borders. And even today, of course, the management wise for this patient, I think that is fine, because if she doesn't have any other disease elsewhere and it is an ovary confined low grade mucinous, she doesn't merit any adjuvant chemo. But prognosis wise, those which are having an infiltrative border or those which are P53 mutated, they have a worse prognosis even among the mucinous carcinomas as compared to the one with pushing borders and which are P53 negative.
Right. So expanding versus infiltrative borders. But endocervical type supposed to have better prognosis than intestinal type. So that's another, I think.
Yes. And also, I think just because they have categorically mentioned endocervical type of mucinous and think it terms to be of an ovarian primary, but whenever we, of course, it is more so if we get an intestinal type of mucinous to rule out that it is a Krukenberg. And for that matter, at least, do a tumor marker for CEA for these patients.
Or tissue immunohistochemistry, what we routinely do CK7 and CK20.
Yes, that would help us. CK7, CK20, CDX2, all those markers. Although, there's quite a bit of an overlap between the two. So usually doing Pax8, CK720, and also Pax8 and CDX2. So it might help us, although there is a bit of an overlap between both GI and ovary.
Yes, we have proceed. Yes. Mahfouz, next slide.
Then the patient was referred to our OPD, and on examination we found she is mildly anemic, accessible lymph node were not palpable, breasts were normal, other vitals were normal. On a per-abdominal examination, wound was healthy. On pelvic examination, cervix looked healthy and no mass could be felt. Next slide. And she was advised for some investigation, including tumor markers, CA125, CA199, CEA, alpha-fetoprotein, LDH, beta-HCG, all were within the normal value. Next. Ultrasonography of whole abdomen was normal. Endoscopy of upper GI tract and colonoscopy were normal. Hearts. Next.
No, this one.
Heart slide review and immunohistochemistry. Immunohistochemistry revealed borderline mucinous tumor with few suspicious foci of microinvasion, CK7 positive, CK20 negative, and secondary carcinoma was excluded.
Unju.
Young lady of 22 years diagnosed as a primary mucinous borderline tumor with suspicious foci of microinvasion who underwent oophorectomy. Next, what will be her next treatment plan?
Observation. Observation and early conception. If she's married and she's trying for fertility, she should. In borderline tumors, there's no need to advise them to wait. In fact, it's better they conceive early.
She has already completed her family, madam.
Okay, she has completed her family. Yes. Then nothing to be done. Like, we keep her under observation. This patient, there's no need to go in now and remove her uterus and other ovaries. So we counsel the patient for the need of regular follow-up, and we keep her under observation and leave the other ovary for hormonal purpose.
Microinvasion. There is foci of microinvasion.
Suspicious foci of microinvasion here, madam.
That's very suspicious kind of thing. So if she's reliable to come for follow-up, I think I will not do another. And if the first surgery it was removed intact, we need to discuss with the patient, and maybe I will, if patient understands, I'll keep her under observation.
Next.
Is actually just
okay.
Just one final.
Okay.
Yeah, one final point. I agree. I totally agree with just observing her, and maybe just use CEA as your tumor marker to follow her, as opposed to a CA125. That might be a more accurate marker for her.
Laparotomy done at National Institute of Cancer Research and Hospital on 19 July 2021. After counseling with the patient, on exploration, we found there was no ascites, no deposit in pus of Douglas, gut, peritoneum, liver, paracolic gutter, undersurface of diaphragm or mesentery. Uterus, left ovary, both tubes looked normal, appendix looked normal. Total abdominal hysterectomy, left-sided salpingo-oophorectomy, right-sided salpingectomy, total omentectomy, right-sided pelvic lymph node dissection were performed. Next. This is our final histopathology report revealed. Unremarkable cervix, wall, left ovary, both fallopian tube, omentum, and there was reactive changes of right-sided pelvic lymph node. Next. These are the specimen after operation, omentum, uterus.
Next.
What is the role of lymphadenectomy in mucinous borderline ovarian tumor?
So if nodes are not enlarged on during surgery, if you don't find enlarged nodes, there is no need to do lymphadenectomy in mucinous tumors. So you may not get the diagnosis of borderline intraoperatively if it's a mucinous tumor, and if nodes are not enlarged, there is no need to do a systematic lymphadenectomy.
Next. In case of primary mucinous borderline ovarian tumor confined to ovary, what is the role of appendicectomy?
So again, if we get this diagnosis intraoperative during, while doing surgery, we generally remove appendix. Having said that, we have rarely seen any tumor in in a normal looking appendix. But we remove it because many times pathologists write, kindly look for appendix in, final histopathology. So, but again, there is no need to do another surgery to remove appendix if it was normal and if you have not removed it at the time of a surgery.
Okay, next. Thank you all.
Thank you, Dr. Manjuman. Our next presenter again, Dr. Farhana Haq. Farhana Haq, please.
Assalamu alaikum. Welcome once again. Mrs. X, 56-year postmenopausal, para 3, living 3.
So once again, can I make a comment before we go to this case? In the previous case, audience may feel there was some discrepancy in or different opinions, but that can happen. It's important to discuss with the patient and family their concerns and see other things, and then take the final decision whether to keep under observation or do surgery. So that's one point I want to make.
Yes, maximum patients in government hospital. We have counseled her several times, but her husband, and our family member, they refused. We want the surgery, then we are not able to come for follow-up. And for that reason, in that situation,
yes, and books also write if family is completed in ovarian cancer, treatment is complete surgery. But in young patient, after counseling and having discussion with the patient family, we tend to keep them under observation if disease is such where other ovary can be left. I mean, of course, if it's advanced cancer, we have to remove. But if it's early invasive cancer, and if patient and family understands, we keep them under surveillance. But completion surgery is also another option. So
yes, before going to this case, there is a question in the chat box that do you need to advise endoscopy to all patients with ovarian mucinous carcinoma?
So if it is, we tend to do for all mucinous especially, but if pathologist clearly write, if it is primary ovarian mucinous tumor, we may not do. So like this case, CK7 positive, 20 negative, CDX2 negative, there were no GI symptoms. I think probably I will not do endoscopy.
We advise this patient as because first time when she came to us with the report, the mucinous cyst adenocarcinoma, without describing any other things. And for that reason, we did advise her all the things, all investigations and all at the patient.
Yes, I think there's nothing wrong doing. I think by and large we also do, except in situations where we clearly have a diagnosis of primary ovarian tumor, mucinous tumor on IHC. AK, what is your practice at your center?
You mean in terms of
GI workup for mucinous tumors?
Yeah, I think we routinely do GI workup. I completely agree with everything you said. I think a lot of times it's negative. But within reason, at least to recommend it. And again, it's sort of probably age related too, in terms of other risk factors.
Yeah, and just to add to that, maybe, that if, of course, we did not have this information earlier, but if it is more than the IHCs, if it is, we have clear-cut borderline areas where the pathologist is sure that this is a borderline tumor with mucinous, like in the final, like how we got. So that case, maybe we'll think it is primary ovary. But if we do not have any borderline areas and it's only mucinous tumor, then many a times there's a lot of overlap between the IHCs.
Right. So yes, that's what I said. By and large, we also do for majority of mucinous tumors, but there are some cases where we may not do. The other limitation of endoscopy is, if many times appendicular primary is missed on endoscopy. So that limitation we need to keep in mind.
Proceed, Neela, proceed. Farhana, proceed.
Mrs. X, 56-year postmenopausal, para 3, living 3, non-diabetic lady presented to a gynecologist with the complaint of abdominal distension for 2 months, pain in lower abdomen for 1 month. At the time, her ultrasonography of whole abdomen revealed bilateral adnexal mass, right side approximately 6 into 4 centimeter and left side about 4 into 4 centimeter with ascites. Ascitic fluid study for malignant cells was negative. CA125 was 13,400 unit per ml, and chest X-ray showed left-sided minimal pleural effusion, and other tumor marker was normal. CT scan of whole abdomen revealed bilateral complex cyst. In the right adnexal region, there is a mixed dense, predominantly cystic and extensoric tumor about 9 into 5 centimeter. And the similar characteristic lesion about 8 into 4 centimeter also noted on the left adnexa with gross ascites. There is the ascites and the mass. CT-guided core biopsy of left adnexal mass was suggestive of serous adenocarcinoma. She received 6 cycles chemotherapy with paclitaxel and carboplatin from September 2022 to January 2021. After getting chemotherapy, her CA125 was 380 unit per ml. Ultrasonography of whole abdomen showed persistence of bilateral complex ovarian mass. Right ovary, right side about 5 into 3 centimeter, left was about 4 into 4 3.5 centimeter with moderate ascites. MRI of whole abdomen revealed persistence of bilateral ovarian mass with gross ascites. Size of the lesion has decreased compared to previous imaging findings. How will we assess her chemotherapy response?
So the other thing I wanted to ask was there a, because you mentioned, I think 6 cycles of chemotherapy, right?
Ma'am.
Yes.
Hello?
Yes.
So was a response assessment done after 3 cycles?
Yes, ma'am.
So, and the decision was taken to continue for 3 more?
Yes, madam. She was on regular follow-up after getting 3 cycles chemotherapy. She was on several imaging, and the tumor marker were done, and she advised for another 3 cycles chemotherapy.
Yeah, so because like usually one would want to go ahead for surgery after 3 cycles. So in her, it was continued in view of ascites, or?
Anna, why have you gone for 6 cycle chemotherapy? Why not tenacity followed by surgery?
Madam, after getting 3 cycle chemotherapy, she was on a regular follow-up. Here our chemotherapy response probably partial.
How do you know?
Why that's documented from her prescription, madam. Documented from her records, previous case records.
Yeah, so I agree, that many a times if they don't have an adequate response and, there are no really guidelines as to what to do for these patients, we also occasionally go ahead with, 6 cycles. But, only 1 or 2 more things which I would want to say is that, especially if after 3 cycles of chemotherapy, we find that the response is not adequate. Yes. And as I understand, like before surgery, before starting chemo, she only had a ascitic fluid cytology, right?
Yes.
So in that.
No, it was a biopsy, Jaya, which from the solid area, serous cyst adenoma, serous carcinoma.
Okay, sorry, I missed that. So then I missed that. Yeah, sorry. So no, because then, of course, if at the baseline, if we had only a cytology, then after 3 cycles, before we move on to further 3 more cycles, then we would definitely want to biopsy one of the areas. But in this case, of course, this biopsy had already been done.
Yes.
So Jaya, let me tell you something. That what you raised the question is a very valid thing, because in our country, the magic number of 3 and 6 always doesn't work. So some of us, the oncologists, to be plain, we keep on chasing. We think that let us finish 6. And the justification is tumor marker. Hardly we do imaging, because once we see the tumor marker is going down, we are so happy. So we want to finish our job by giving 6 cycles. We talk with our surgeon colleagues and after 3 cycles. And then once it is finished, then we send the patient to the surgeon colleagues. Hey, now we have finished, now do your job. So that is one part. I'm not telling that what happened to this patient, I don't know, but that is not a common, but many people practice like that. So that is one thing. So the message here is, we discussed in this platform earlier, the CA-125 should not be a sole modality of assessing the response. Imaging should be the modality. And this was discussed by Amita quite a few times, I remember. And it should be after 3 cycles. If not, then both of the surgeon and the oncologist can discuss to give 1 or 2 more. But on art, one should not exhaust all the 6 cycles, because then the question comes that if 6 cycles is given, surgery is done, shall we give some more or not? Because again, the magic number 6, I remember that where from it came, we don't know that. Because there are guidelines telling that more than 6 is not that much beneficial also.
So we can go up to a maximum of 8, and that is as per, icon 5, we've had a maximum of 8 number of cycles. So, so usually we do it after 3 or 4 cycles, we do interval debulking and then give another 2 to 3 more cycles. But, there are occasions where, on CT scan, the ascites has reduced, but is still there. There is extensive peritoneal deposit. And like in our part of the country, the CA-125 may have been some 10,000 and it has come down to 1,000. So in spite of response, the surgeon feels that, we may not be able to achieve an R0. And in that situation, we don't know what to do. And then we give 6 and then 2 more cycles. So Dr. Amita can say on that also, yeah.
Yeah, I think this issue we have discussed before also. So these are occasional cases where we have to give more chemotherapy, 6 or whatever. But generally, and the rule is first assessment should be done, like, the first surgical evaluation should be done after 3 cycles. So, imaging and CA-125 and of course clinical assessment. So we have to take all these things into consideration and not to keep giving chemotherapy till response occurs. So, and I think there is increased risk of chemo resistance if we give 6 cycles or more cycles of chemotherapy upfront.
Yeah, completely agree, that 6 should be the exception rather than the rule. And of course, we will do after 3 cycles. And in fact, if you look at the older meta-analysis, so that is driven by biology also, that, the more number of neoadjuvant chemotherapy that you give, the worse survival that you get. So I think, those are the things that we need to keep in mind.
Yeah, I think the message is first assessment should be done by a surgical colleague after 3 cycles of chemotherapy. So patient should be jointly evaluated after 3 cycles. And, if suitable for surgery should be performed then, and then give remaining chemotherapy.
Mila, only CA-125 was done after 3 cycles or other imaging?
No, imaging was there, which showed imaging. She mentioned in detail. There was a site. Okay, after 3 we don't have. Okay, she has not.
Madam, after 3 she advised for CT scan and CA-125.
What is that finding?
These were documented in her record file, but report was not showed.
Okay, next.
Hi. So I totally agree with everyone's comments. And I, of course, love what Dr. Kamal Sir says about the sort of 6 versus 3 cycles. And just to add one more point, again, it sounds like we're missing a little bit of information here about usually we like to get a CA-125 with each dose of chemotherapy so we can graph out what's going on, maybe physical examination, performance status, all the assessments that we do to help understand how someone's doing. Definitely repeat the scan after 3 cycles. But the other issue to consider in terms of surgery is information, right? We have an FNAC, maybe this is colon cancer, maybe this is something that you're not expecting it to be that would completely change what you do. So another thing to think about, especially if someone's not responding, is it truly just platinum resistant ovarian cancer, or potentially are you dealing with something different? And would a laparotomy with removing the mass, doing an omentectomy, even if you don't or are unable to do a complete cytoreductive surgery, give you additional intel that will help you decide how to further treat your patient, as opposed to wasting her time with chemotherapy that will not work if 3 to 4 doesn't work.
Yeah, completely agree with you, Dr. Goodman, because, you know, there are times when we've had young patients who have, you know, good performance status and they have no response to chemotherapy, and patient is walking around in ECOG-1 and CT scan shows no response. And these are the patients who could be having low-grade tumors, and therefore, even though we don't do a laparotomy, many times we just go ahead and consider her for a CT-guided biopsy of those lesions. So as you rightly mentioned, Krukenberg and of course, low-grade tumors are other things that we need to think about. Yeah.
So what will be our next management plan?
So I think we agree that we would consider her for surgical intervention at this point. The only thing is, if you still have some concern, a scope can be put in before you make a laparotomy, because if there is extensive peritoneal carcinomatosis, if she's has disease which is not amenable to cytoreductive surgery, that laparoscopy may give some clue. Otherwise, we can go for laparotomy also, open surgery.
Yes, madam. Then she received 4 cycles of chemotherapy with gemcitabine and doxorubicin from February 2021 to May 2021. After that, she attended our OPD for further management.
So, sorry, I did, Dr. Jaya, here that, you know, this patient, from what I understand, is she had a response to chemotherapy, right? Because the CA-125 came down, if I've not missed out on anything, and her ascites and other things reduced, right?
Madam, after getting 6 cycle chemotherapy, her CA-125 was 380 unit per ml, and her MRI of whole abdomen showed persistence of bilateral ovarian mass with gross ascites.
So was there no response to chemo after 6 cycles? What was the baseline CA-125?
13,400 unit per ml before getting the first.
Okay, so so her CA-125 came down from 13,000 to 300. And ascites, was she requiring repeated tapping, or even though there was ascites present, was there a clinical response in terms of ascites getting tapped, or?
Repeated tapping.
I think there was, and you know, her pleural
sorry?
effusion at least has responded, isn't it? She had pleural effusion to start with, which had responded to chemotherapy.
Yes,
so Joya, if I'm allowed, let me tell you what happened. Again, there was some partial response,
yes.
And the patient was chased with 6 cycle, and then we take a decision that 6 cycle is given. So we go to the next protocol, is gem doxorubicin. I think is it gem doxorubicin or gem docetaxel? I don't know. Okay, gem doxorubicin. So they have changed from Pacli to gemcitabine. That is what happened here.
No, so there are two things. One is that if she's had any form of partial response to platinum, I will definitely give her 2 more cycles of platinum.
Exactly.
So our practice is to give them the same 2 more cycles of paclicarbo, because really we do not have the data to show that, changing helps. And if at all we have to change, then it is the platinum partner that we may change, be it gem platinum or doxo platinum. But definitely if there's a response to platinum, and if there is a partial response to paclicarbo in the terms of pleural effusion and everything resolving, then I would just go ahead and give her 2 more cycles of same chemotherapy with paclitaxel and carboplatin.
I totally agree with
this lady is going to relapse. This lady is going to relapse at some point. And, then if I've used up 2 doxor now, and, changing chemotherapy now versus later, really do not know whether that makes a difference. So I think would continue with the same 2 cycles if there is no neuropathy.
So let's see this now. What is the present condition?
At our department, on examination, all vitals were normal. No mass or organomegaly lymphadenopathy were found. Breast was normal. Moderate ascites was present. On pelvic examination, no abnormalities could be detected.
No, so this ascites was present when, after how many months of completing the chemotherapy?
Madam, 1 month later.
Okay, so we changed to gemcitabine and doxorubicin, and within a month she presented with ascites, right?
Yes, madam.
Okay.
Her CA125 was 80 unit per ml. Carcinoembryonic antigen 120 nanogram per ml. Other tumor marker was normal. Chest texture normal. Ultrasonography of whole abdomen showed bilateral complex adenocysts about 2.5 to 2 centimeter and 3 to 2 centimeter with moderate ascites. Endoscopy of upper GIT normal. Colonoscopy findings was colonic polyp. Histopathology was hyperplastic polyp. In this case, what type of advanced imaging should be advised, CT scan or MRI?
So just for one clarification, so did she undergo the surgery or did she not? Because it says adnexa still present. So
no, I am just explaining. She first received 6-cycle chemotherapy with paclitaxel carboplatin. Before that, her tumor marker was more than 13,000 C125, and there was a huge bilateral ovarian mass with ascites and probably pleural effusion. Then she received 6-cycle chemotherapy. After 3 cycles, she was evaluated and her tumor marker was slightly lower, and she continued another 3 cycles with the same protocol, paclicarbo. And after that, without doing surgery, she again received the 4-cycle chemotherapy with gemcarbo. And 1 month after getting 4-cycle gemcarbo, she attended in our hospital. And before starting gemcarbo, her C125 was probably 315, and the size of the tumor was 6.5 into 4.5 bilateral, but there was gross ascites probably. And again, she received the gemcarbo. Now the status is still patient is not undergone the surgery.
So, and just I wanted to ask, was the baseline CEA normal? Because the current CEA is 114.
Yes, madam. Baseline CEA was normal.
Okay. So I would think she already has an advanced disease. So I don't think an MRI is going to give us any further advantage. And I would go ahead with a contrast CT scan of, because she had baseline pleural effusion also, a contrast enhanced CT scan of the thorax, abdomen, and pelvis.
Madam, before getting second-line chemotherapy, she advised for MRI of whole abdomen. For this situation, particularly in this case, what type of advanced imaging should we advise, CT scan or MRI?
So I think CT scan, what we want to see in this situation is just not adnexa. But what we also interested in upper abdomen, you know, when we think of operability. So what is what we want to see? Peritoneal disease, bowel surface disease, peritoneal carcinomatosis kind of thing. And for that, I feel CT scan, contrast CT is better than MRI, especially for evaluation of upper abdomen. And also for evaluation of, you know, pyloras or gallbladder, if you are thinking in terms of Krukenberg. So I'll do a CT, not a MRI.
Okay, madam.
And also, you know, if she now has recurrence of ascites within, like, say, 6 pachycarbo and then 2 cycles of gemcitabine and doxorubicin, and now if the baseline diagnosis was a high-grade serous, she's essentially like almost like a platinum resistant or maybe refractory disease, because, you know, after stopping platinum, she's got 2 cycles of gemcitabine doxo and now has recurred. So if she was high-grade serous, the situation is essentially palliative now, because with platinum refractory disease and also, you know, having received 2 agents altogether also for resistant disease, if she's still progressing, I think it's largely palliation, you know, Dr. Amita.
Yeah, the only thing is she has never been subjected to surgery, and if her performance status is good, she's a young lady, I think 56 or something, we would consider surgical intervention. The other one thing I want to know about liver status and albumin.
So this is the city. This is the city.
Yeah, CT is showing ascites.
Yes, there is a moderate ascites is noted and persistence of the bilateral ovarian mass.
That's okay. How much is our albumin? Did we look at albumin?
Albumin was normal, madam.
Okay, and I mean, if performance status is good, I would still, you know, she has never been subjected to surgery, so I would consider surgery. Maybe a diagnostic lab followed by laparotomy if disease is operable.
Can anybody try Parfi here?
Next, ask this.
I think this question have already discussed. What will be our further management? Amita madam already discussed.
Okay.
She underwent debulking surgery on 7 June 2021. Her perioperative findings, 1.5 liter ascitic fluid was present. There was no metastatic deposit in peritoneal surface of abdominal cavity. Both ovaries were approximately 4 into 3 centimeter in size and adherent with uterus, and omental deposits were present. Total abdominal hysterectomy with bilateral salpingo-oophorectomy with total omentectomy was done. Here is the perioperative figures. Complete cytoreduction was done. Her final histopathology report revealed papillary serous cyst adenocarcinoma of both ovaries, metastasis present in the omentum.
So what is the grade? Is it high grade or is it low grade? Because it's like papilla.
Previous slide, Neela, histopathology. Yeah.
Grade is not mentioned here. Their chemotherapy response score 1, no or minimal tumor response.
So, you know, it will become very important to know whether she is low grade tumor or not. I mean, because she had no response. No, serous is not always high grade. So serous or papillary it could be a low grade serous or it could be a high grade serous. The reason why I'm asking is because if it is a low grade serous, then, you know, and we do an ERPR on that, and then low grade serous, there is a role of maintenance hormonal therapy.
The core biopsy report was high grade, probably. Farhana?
No, madam, only serous adenocarcinoma.
This was mentioned. Yeah.
Okay, so then it becomes all the more. So in this.
Yes.
Yes, madam. So what will be her next adjuvant therapy?
So, as I said, of course, first check the grade. And if grade is low grade, then we would put her on maintenance hormonal therapy. If the grade is a high grade tumor, then it's a difficult question because she's already received some 8 cycles of neoadjuvant chemotherapy. And I really do not know, and there is no response to treatment as such. So I'm really not sure as to what is the right answer in this patient. I would probably just observe her because she's already received 6 platinum and 2 of gemcitabine and docetaxel with no response. Yeah.
Still
But I think I would make an endeavor to know the grade and the.
But why you say no response? Because her CA 125 from 14,000, it has come down to less than 100 with some 7-8 courses of chemotherapy. On histopathology, yes, I mean on I think histopathology there may not be chemo related changes, but tumor has responded. A pleural effusion has gone, and of course other sites we don't know before, but there is a response to treatment.
So meaning that if this surgery had been done after 6 cycles, I would have continued with 2 more cycles of paclicarbo. Now she's received 6 cycles of paclicarbo. In between, she's received 2 cycles of gemcitabine and doxorubicin.
No,
no, it is written gemcitabine with doxorubicin is what is written in the.
Yes, madam.
So if she's received
gemcitabine, doxorubicin for 4 cycles.
So she's already received 6 plus 4, 10 cycles of chemotherapy, right?
Chemotherapy, yes, madam.
So then I really not sure giving any more chemotherapy is, I mean, going to make any difference to her. I mean, if you, I mean, see, there's no right answer in this. I mean, one can observe or give her 2 more cycles of just doxorubicin to complete 6. So, but I don't know. I mean, really, there is no one answer to this. Because this is not what a usual situation is. Because after 10 cycles of NSCT, giving any more adjuvant chemo, I really don't know.
So another thing, yeah, I completely agree with everything. You could consider some sort of a maintenance therapy like bevacizumab, or if you think she's platinum resistant, you could just think about Doxil and bevacizumab and do that. But I definitely support the idea of checking the grade of this tumor. That's a very, very smart thought because it might explain why it's not that chemosensitive. You have some response, but not complete response.
All right. All right.
Yeah, I agree with like if we are not doing anything, then maybe just, and if it is still high grade, then we can continue with 2 more cycles of liposomal doxorubicin, and you know, if it is high grade plus minus bevacizumab, yeah.
We can, I don't know why we labeling her as platinum resistant. I'm not sure whether she's fully platinum resistant.
No, she's platinum
sensitive.
That platinum sensitive. Sorry. No, what I'm trying to say is that she's platinum sensitive, but there's a break in the platinum. So then again, you give 6 platinum, then there is non-platinum. Then again, going back to platinum, we are not maintaining any dose intensity of the platinum. So even though she is, you know, of course, she was not platinum resistant to begin with, but the chemotherapy, because of whatever circumstances were changed, and now she's received a non-platinum agent in the last 4 cycles. So the immediately pre-chemotherapy were non-platinum agent. So therefore, if, at least to maintain the dose intensity of that doxorubicin, you can just continue with 2 more cycles of liposomal doxorubicin. Yeah. Sorry, Dr. Amita, you were saying something.
All
Is
right.
there any risk of...
Shana?
Shall I
I
proceed?
have any comment? But usually, as you know, when we do this type of surgery, the patients usually they get chemotherapy. What is your opinion in this situation?
No, my opinion is, in ovary, this is a never-ending game, surgery and chemotherapy. But, I mean, you need to make a combined plan. If it is an independent plan, that is a problem. So
Yes.
as Amita and Jaya was telling, she was platinum sensitive, but maybe we could have done the timing of everything in a different way. This is number one. And number two, as long as there is some response showing, so we can, I agree with Jaya, and definitely, I mean, if the financial toxicity is not an issue, she could be a candidate for PARP maintenance.
Yeah. Sorry, only thing before PARP inhibitors, of course, is recommended for those who have had a platinum sensitive, I mean, who've had an initial response to platinum. And of course, we would also want to check her BRCA status. And of course, even though it is recommended, irrespective of BRCA status for niraparib, the problem is that the magnitude of benefit for those who are BRCA positive is close to 12 months. But the magnitude of benefit for those who are both somatic and germline BRCA negative is 3 to 4 months. And then by the very nature of this patient, and platinum sensitivity is a surrogate marker for PARP sensitivity. So in this patient, although she's platinum sensitive, but she's not had the classical response how we would expect, with complete resolution of ascites and her tumor markers coming down and her being able to have a surgery after 3 or 6 cycles. Because even at the end of 6 cycles of platinum, even though she's platinum sensitive, she still had like gross ascites and disease which was left behind. So the benefit we can offer PARP, but the benefit of PARP in such a patient, especially if she's BRCA negative, is going to be very, very limited.
Jaya, thank you very much, because you have said what I wanted. It was a devil's advocacy that I was pushing for the PARP, because in our country, generic PARP is available. So we are a fan of PARP now. So whether we should use it in a fast line on a recurrence setup, in all these things, and whether it is a BRCA positive or negative. So we are always picking up the small logic to justify it, like, well, it was a sensitive, well, there is a recurrence. Well, I mean, many well. But the problem, as you mentioned, that the benefit in BRCA negative is so small. So even it is a generic is costing a good amount of money. So many of our colleagues, they became a big fan of PARP. I hardly used any PARP in ovarian. Still, I got an ideal candidate. But it is so widely used in our country. It is, so all the points that you mentioned, I wanted to hear. That's why I was just making the devil's advocacy, that indiscriminate use of PARP, even there is a big role in ovarian malignancy, should not be there. So it should be judicious and justified before going for PARP. That is the discussion, I think, from here we should tell everybody.
See.
Role of PARP inhibitor already discussed. Is BRCA testing mandatory before giving PARP inhibitor?
Oh, so it is not mandate. I mean, platinum sensitive, but I think for us to counsel the patient and know what is there, and for olaparib presently it is approved for those who are BRCA mutated. So I think because we'll be expending so much on PARP inhibitors, and otherwise also for all high grade, serous ovarian cancers, it is recommended to do germline testing for these patients. So I think it is a good idea to do a BRCA testing before we discuss PARP inhibitors.
Yeah, and as Jaya mentioned, this testing, genetic testing, has implications for other family members and for the patient as far as breast screening is concerned. So if someone who can afford PARP inhibitors can very well, I think, undergo testing. So I feel we should test before starting PARP inhibitors.
Yeah, the cost is half month drug cost.
Yeah.
Cost
So
of the testing in the half month, that cost.
yes, so many, it's almost some of these companies are offering almost free also if you are taking PARP inhibitors. So I think cost is not a concern for someone who can afford PARP inhibitors. So we should test.
Is there any role of
It is
bevacizumab
already
in this case?
discussed. Jaya mentioned about the use of bevacizumab.
Yeah, Dr. Goodman had also mentioned regarding
Yes,
maintenance bevacizumab after.
Especially when there is some fluid, bevacizumab could be a good choice.
Next.
Yes, like platinum sensitivity is a surrogate for BRCA, PARP response. Similarly, ascites has been, as you, Dr. Kamaluddin, is a surrogate for response to bevacizumab.
Yes.
And that is, and also, if you look at, the TCGA data set is the one which are mesenchymal subtype, the ones with ascites, they are the ones who benefit more from bevacizumab, although we don't use that so much to tailor response, but that is something that we need to look at.
Thank you, madam.
Thank you, Dr. Farhana. We have another case, but I think we should not proceed more. Yeah, one more case, but I think we should not proceed today because it's already 10:25 and the number of participants are less. So in future, but we didn't discuss the poll questions. We didn't given the now. Mahfouz, please show the poll questions. There are some questions during this time. I am asking, there are some questions in the chat box. Kamal bhai, there was a question that in the first case of the Dr. Farhana, there is a serous type of adenocarcinoma with bilateral pelvic and parotid lymph node positive. Somebody asked, is there any role of the extended field radiation to cover those?
In that type of situation, main player is chemotherapy. And then we say that after the end of radiotherapy or chemotherapy, we can give radiotherapy. Yes, as there is parabiotic involvement, so to cover it, we can give extended field radiotherapy. There is, but the problem is in this type of situation, stage 3C with serous, the role of radiotherapy is not that great like other endometrial carcinoma. AK, any comment on this? Okay.
Yes. You are muted. You are muted. You are muted. Please. AK, you are muted. You are, please unmute yourself.
Okay. So, yeah. Sorry, I was pushing and squeezing. No, I agree with Kamal. Yeah.
Another question is in a borderline ovarian tumor, patient is 22 years, whether family is complete or incomplete. We could follow up the patient or should we go for the surgical staging? That's about the first case.
Amita?
I'm pulling done.
Okay, just stop and show the winner.
So, AK, would you like to comment on this? Because the classical borderline, 22 years, either family complete or not. So, I mean, as guideline, if I'm not wrong, there is no recommendation for surgery. We can put on observation, no need of this radical surgery. If it is a real borderline, not even a chemotherapy is now warranted if there is no high risk feature. So what is your take on 22 years lady, family is complete or incomplete? Does it matter about the decision of surgery?
Right. I actually would have gone with close follow-up without further surgery at this point for a borderline tumor. You know, the one interesting piece, and maybe in a future tumor board, because everyone needs to go to bed where you are, and maybe I need to take a nap where I am, but maybe for a future discussion to invite a pathologist to discuss the issue of microinvasion in borderline tumors. That's actually a very interesting pathological discussion, but for a future date, because there's too much, you guys need to go to bed. But I would say, even with that, I would probably just follow her closely. Yeah, without further surgery.
In our situation, when family is complete, and if we doubt about that, patient will not be in follow-up. In that case?
Yeah, no, I completely understand. You're being very pragmatic, and there's no wrong answer. So with good counseling of the patient, you absolutely could do completion surgery, which you did. But in an ideal world, there is probably benefit in terms of reduction in overall mortality rate in women in preserving her other ovary, right? We have information that ovaries do good things. And if you have a normal ovary in a 22-year-old, removing it probably may shorten her life from a cardiovascular point of view. And since the risk of recurrence for the mucinous tumor is really quite low, usually they're unilateral, you could make an argument that surgery may not be ultimately beneficial, unrelated to GYN oncology, but related to her whole life, right? So that needs to be factored in your decision-making when someone is so young.
Okay,
So then also the morbidity
Shahana. Sorry, Joya, yeah, please go ahead, Joya.
No, so just and also the sheer morbidity and the difficulties that she's going to undergo, you know, that is so much untold of, you know, especially her symptoms, her vascular symptoms, the hot flushes, that is so incapacitating at times that, and especially for a 22-year-old, you know, somebody close to 40, 45 is still, but for somebody 22, that really also adds on to a lot of morbidity.
Yeah, and what I want to add with Shahana, that nowadays, I think we should not be judgmental. We can say that there is a less chance of regular follow-up, but we cannot take a preemptive decision that she may not come for follow-up, so we go for surgery. We can counsel, and if they agree to come for follow-up, if they don't come, then it is their call. Because end of the day, assuming that the patient may not come for a regular follow-up, probably is not a logical thing today in 2021.
Marcus, please show the poll winners. I think all the questions has already answered. Marcus, show the poll winners, please. Dr. Rita Shankar, Atana Mahapus, Nazni Nara. Please put your phone number on the chat box. All the three winners, Dr. Rita Shankar, Dr. Farhana Mahapus, and Dr. Nazni Nara. Thank you very much. Thank you all the presenters and all the faculties and also the participants. We are very much happy that today we have around 150 participants. Now I request our scientific secretary, Dr. F.M. Kamaluddin Bhai, to make few comments, and then Kamaluddin Bhai, please.
So thank you, Shahana. I mean, nothing much to comment because it was a long day. I think so many cases, wonderful cases were discussed, and thanks to all our faculties. And I know today you are not in a good situation, but still you are carrying the program. So like always, congratulations to you and your team. And now you have created a team of the inside country and outside country. I see that you have expanded your spectrum. So you have created some overseas team and a local team. So all the faculties are also member of your team. So I'm congratulating both the part of your team for creating such a wonderful environment for all of us to learn. And hopefully this will continue. And we will be enjoying more into wonderful sessions on coming days. Thank you.
Thank you.
Thank you.
Thank you so much. Thank
you so much. Yeah, and very interesting cases we discussed today. Thank you, Dr. Shahana and all presenters.
Jaya and Amita, I have one suggestion to Shahana, that so many nice cases she is discussing. Why not they compile it up? Because end of the day, she don't know what treasure she has collected. If all things are gathered, I think it will become a wonderful treasure. I know she is nodding her heads because I am giving some new assignment, but it could be a great thing if they can really gather all these cases. What do you think, Amita?
Yes. Some, and especially some unusual ones, definitely, and some of them are worth reporting also. So everyone learns from such unusual and interesting cases.
Exactly.
Yeah, and I think it's been a learning for us as well. Yeah, thank you.
Thank you. Good night.
Thank you very much.
Yeah.
Bye.
Now I request our president.
Thank
you. Hi, sir, to conclude the session. Sir, please.
Okay, thank you, Shahana. Had a very nice evening today. Very beautiful, complicated cases were discussed. A lot. And I give with the proposal of Kamal, try to sum up something out of this, so that our future generation can get benefited from this. Thank you all very much, and goodbye. We'll see you next Sunday.
Thank you, sir. Thank you very much. Thanks to all the participants.
Yeah. Thank you.
For the next session.